Good morning, everyone, and welcome to day 2 of the ThyCa conference. My name is Roberta Perry, and I will be your host today. This is the session called Discussion with the Doctor about Anaplastic Thyroid Cancer and Hurthle Cell Thyroid Cancer, What's New? Today's presenter is Dr. Dr. Lorch. He will be moving to Northwestern University at the beginning of next month, but his bio as it is now states that he's the medical oncologist at Dana-Farber. And he's also, excuse me, the director of the Thyroid Cancer Center, clinical trials leader, director of the Endocrine Center Treatment Center, and associate professor of medicine at Harvard Medical School. Dr. Lorch is board certified in hematology, internal medicine, and medical oncology. His clinical interests include head and neck oncology and thyroid cancer.
Well, thank you, Ms. Perry, and good morning, everybody. So as in past years, I would like to keep this as interactive as possible. Obviously, when we're not in one room together, but if you don't hesitate to electronically raise your hand and ask questions as we go through this material. I did prepare a bunch of slides, but I think it always works best if there's a lot of feedback, and I'm happy to follow your lead in whichever almost any lead, direction you would like. So we're talking about anaplastic thyroid cancer and Hurthle cell cancer. It's kind of a funny combination, but actually it turns out these two things have a little bit more in common than we initially thought. So I'll mix the two as I go through through this presentation. Some will be applicable for anaplastic, other stuff will be applicable mostly for Hurthle cell, but so you have to bear with me. So anaplastic, as you all know, is an orphan disease, which is, there's just a little more than 1,000 cases per year, but it's very devastating. That actually accounts for about half of all thyroid cancer deaths. Extremely aggressive, very fast growing. Median survival, at least in the past, used to be 4 to 6 months, although I think that that's changing rapidly. 1 year survival used to be between 0 and 10%, but again, that also is actually changing very rapidly. There is, to date, no standard of care except for cases where there is a BRAF mutation, this BRAF V600E mutation in most cases. And in those cases, there is a combination of dabrafenib and trametinib that is quite effective, at least for some time, with a response rate of about 65%. Hurthle cell cancer is also rare. It's one of the more rare forms of follicular thyroid cancer. However, if you look at the iodine refractory group of patients with thyroid cancer, there, the Hurthle cell cancer is clearly overrepresented. It's about 1/3 or so of all iodine refractory thyroid cancer cases. And it's because it's almost never sensitive to radioactive iodine. A hallmark, genetically speaking, is that there is a relative paucity of genetic mutations. So BRAF is virtually never, I think I remember one case where it was positive. Sometimes you find RAS mutants. There has also lately been some discussions around recurring mutations in the mitochondrial DNA. So mitochondria, as you recall, are these little energy producing organs inside a cell. They're actually derived from bacteria that probably became part of us and many other animals and similar things a couple million years ago, and their purpose is to produce energy. They're largely responsible for turning oxygen and carbohydrates into energy. And there are some mutations that recur in Hurthle cell cancer, but it's not entirely clear if that is actually something that these cancers need, or whether that's just sort of a bystander problem that just happens to be there. It's very hard to analyze mitochondrial DNA because it's inherently very unstable. So you always find a lot of mutations in it. So there's still some question marks. But what they all have, and I think that's very meaningful, is that they have this near complete haploidization of genome. So as you know, we have two sets of chromosomes, one mostly from the father, other from the mother. And they're mixed and so on, and that's what constitutes our genome. So we have basically two tapes for us. For every gene, there's two copies, and for in Hurthle cell cancers, one copy is almost completely lost, with the exception of 2 or 3 chromosomes. But otherwise, these tumors have only one set of chromosomes, which means that if a somewhat minor genetic event occurs, that actually has a lot more bearing potentially, because you don't have these cells don't have the healthy copy from the other part of the chromosome, from the other set of chromosomes, where they could just switch over and produce the healthy protein. So this is a very, very classic and very almost universal genetic sign of Hurthle cell cancer. Very strange. It does not occur like that in other cancers. Now for Hurthle cell cancer, not so much for anaplastic thyroid cancer, but for Hurthle cell cancers, Lenvatinib is the standard of care. As you probably know, there was a phase 3 study, a randomized study with almost 400 patients, was randomized to people receiving Lenvatinib, a multi-tyrosine kinase inhibitor, versus a placebo. And then the question was, who progresses faster? Eventually, everybody got the active drug once they progressed. So progression-free survival, therefore, was the appropriate endpoint. And people had to have progressed previously, and the results were quite striking. So there were 18, in all iodine refractory thyroid cancers, people on Lenvatinib progressed after approximately 18 months, and those with placebo progressed after about 4 months. So that established Lenvatinib as the standard of care in this disease. Was published in the New England Journal. And many of you have probably been on it or are on it, and it works beautifully. The problem is that this is also a very toxic drug. So there's issues with blood pressure, fatigue. If you're not careful, you can actually get stomach ulcers, bleeding stomach ulcers. And a number of other complications. I've seen people getting strokes and all kinds of vascular problems, which has directly to do with the way this drug works. But it works quite nicely. Eventually, though, and that's the other problem with it, is that the tumors become resistant to it and start to grow again. And typically that happens after about a year and a half, although that's just sort of a median. The median progression-free survival is 18.3 months. So, which means by definition that about 50% actually progressed sooner and another 50% progressed later. Now, if you look at who benefited the most, it was really pretty much the same across the board. And Hurthle cell is actually right here, and the benefit was actually just more or less the same as with all the other cancer types. There was no real statistical significance in any of this. So, and Hurthle cell does respond beautifully. But then what do we do? So this is a standard, it's FDA approved. Your oncologist can just write, or endocrinologist can just write a prescription and you'll be on this. What else is out there if this fails? We've tested a couple of years ago, we've tested a drug called Everolimus, which I keep mentioning because it's frequently overlooked, and it works particularly well in Hurthle cell cancer. Lenvatinib, by the way, at least by itself, does not seem to have any value in anaplastic thyroid cancer, which is not to say that I haven't seen any responses. I have. but it's quite rare. There was a phase 2 study where Lenvatinib was in about 30 patients. The trial was planned to actually be larger, but after 30 patients, they stopped because there was only one responder. It may be a little different when combined with immunotherapy or some other modalities, and we'll talk a little bit about that. But right now, in anaplastic thyroid cancer, lenvatinib doesn't really have a role. So everolimus is a drug that's actually been around a long time. It's derived from rapamycin, which is derived from a bacteria that lives in the soil of the Easter Islands, or Rapamui. That's where rapamycin, the word rapamycin, the name comes from. So everolimus is essentially a variant of that. It's very specific. It inhibits this molecule very, very effectively. And it then, when it does inhibit this, it does block the mTORC complex 1, which is part of the PI3 kinase pathway. This was our study. There were 2 other studies out there, and we had iodine refractory thyroid cancers. Among these 33, there were 12 patients with Hurthle cell cancer. And again, it's about a third or so of all iodine refractory thyroid cancer patients, and then also 7 patients with anaplastic thyroid cancer. This was the results overall. So there was no control arm. It was a one-arm single center, or MD Anderson was participating too. So it was several centers, but it was one arm. There was no randomization. There was no control group. So so we only could compare this to historical controls. And the progression-free survival was 12.3 months. Which was encouraging in this patient population. And since we're talking about Hurthle cell, these were or 11 patients we had who could be evaluated with Hurthle cell, and there the progression-free survival was 11.7 months. We included patients only if they had progressed within the prior 6 months. So this was a good result. And still about 16% were still on the drug at 2 years. And I have seen people go all the way to 7 years. And as I said, this is not a new and exciting drug. It's been around for a while, but there are now generics, which also means that it's cheap. You don't have much issues getting it through your insurance. And it really works. In many cases, it works well. I have yet to see a Hurthle cell cancer that does not respond to everolimus. And as I said, it's always an easy one for me because patients often come after failing lenvatinib, and this is easy to get, and it works. The side effects, it does suppress immune system, so you have to be careful with things like sinusitis, bronchitis, things that sore throat that you would just wait, or a cough you would just wait for it to be over. While you're on this drug, you have to, the threshold to start an antibiotic is very, very low because these things often then don't go away. But otherwise, it's very manageable in many ways. I find it easier on average than lenvatinib, and a drug to keep in mind. Then in this trial, as I mentioned, we had 7 patients with anaplastic thyroid cancer, and 2 patients actually had a prolonged response, and one is depicted here, which we published in the New England Journal. But this was, so she had recurrence, typical story, rapidly enlarging neck mass, got surgery, chemoradiation. By the time she was done with chemoradiation, she had a recurrence in the chest, which then responded to everolimus somewhat unexpectedly. We sequenced her, and she had a TSC2 mutation. It's a tuberous sclerosis complex 2. Again, this is something that explains perfectly why she had such a nice response. But then after about 1.5 years, she progressed again. And then we did a biopsy, and then found that there was a new mutation that was actually binding preventing the binding of the drug to this very specific spot in the mTOR molecule. So that was scientifically neat. When we could do some MIT style stuff with it and modeling and so on, it could show, yeah, this mutation is indeed responsible for resistance. This has also since been described in breast cancer and some other cancers that are also treated with everolimus quite commonly. And what we could also show was that another mTOR inhibitor, not rapamycin, but another mTOR inhibitor should still work. And based on that, we had another trial with a drug called MLN0128, MLN for Millennium, or Takeda. They've been bought up. We've since also, we've completed this trial. We have seen some responses in anaplastic thyroid cancer, although it wasn't quite as impressive. But it was definitely a very useful drug in iodine refractory thyroid cancer, and particularly again in Hurthle cell cancers. Those responded really well. This is also, what's cool is this is a drug that's actually quite easy to take. So there's no immune suppression like compared to Everolimus or pneumonitis, where you can have this inflammation of the lungs. This drug does not do that. It's generally pretty easy. Fatigue is the main side effect, and it worked quite well in a number of cases. So we're putting together a paper to publish those results. Unfortunately, Millennium decided to not develop this drug further because it failed in breast cancer, or it sort of semi-succeeded, but it mostly failed. And then the company lost interest in it. It's in the process of being sold to somebody, and I don't know if they will continue to produce it. But again, if you find a trial with a second generation mTOR inhibitor, and you have Hurthle cell cancer in particular, but also iodine refractory thyroid cancer, this is a good option. I would recommend that. Yes, and then of course the question is, which the patient that I had described earlier with this wonderful response and then eventually resistance, so she actually lived to participate in her own trial, in this trial that was with this drug MLN0128 that was based on the resistance mechanism that we had found in her. And the reason why I can show you her picture is that she actually had consented to having her story published in the New York Times and in the Washington Post, and so on. So this is actually her with her grandson. Her daughter here was pregnant with her grandson when she was diagnosed with anaplastic thyroid cancer, and at the time she did not think that she would live to see him, but she did, and there she's holding him. And this is actually her daughter who just gave birth. There's also a funny story because these pictures were taken for the Washington Post. The people from the Washington Post, were a reporter and a photographer, were coming up to participate in a family dinner. While they were there, or on the way there, her daughter went into labor. So they diverted everybody to the hospital. And so this was taken by a Washington Post photographer. But the big question is, did she actually respond to her own trial? And she did. This is a scan of her cross section, and it got a little bit smaller. She eventually did fail, but that was obviously scientifically very intriguing, and we're very happy to see these the scans when they came out. So what else is there in anaplastic thyroid cancer? Well, I mentioned the dabrafenib plus trametinib. This is the data for this trial. This was part of a larger trial with BRAF mutant anaplastic or BRAF mutant tumors, period. And there's a number of them. There's melanomas, and there's colon cancer that's BRAF mutant. They all have the same. They share the same BRAF V600E mutation. And this was a subgroup of this trial, 16 patients, and there they found the response rate of 69%. And after about a year, there were still, or a little more than a year, there were still 7 patients on it. 12-month estimates were 90%. With progression-free survival and so on. So this was all very very encouraging. FDA approved this drug based on 16 patients, which I think is the smallest sample size for an FDA approval that I know of. But as you can see here, this was the shrinkage of these tumors. So the lower the bar here, the more negative this bar is, the better, the more shrinkage you have. And then there was one complete response, and then a lot of nice shrinkage, some shrinkage here that did not meet the criteria for actual radiographic response, but still, they weren't getting bigger. Only one got bigger. I have to say that, and I've used this many times in the meantime, I have to say it is, you do see these responses every once in a while. You see the responses often, but in my experience, they often don't last very long. I find that the cancer often comes roaring back within a few months, even weeks. I mean, the data are what they are. I'm sure they've done this all correctly, but it's not, in my opinion, it's not quite as useful as it was in those 16 patients. Obviously, there are many other mutations that occur in thyroid cancer, and one of them is RET. That is actually famous for mutations that occur in medullary thyroid cancer that activate the molecule and then activate MAP kinase signaling, and that's then done through a mutation here that brings two molecules together, and that leads to activation through this phosphorylation here, and or it can be a direct activating mutation. That's what happens in medullary thyroid cancer. However, in papillary thyroid cancer, and also to some degree in anaplastic thyroid cancer, dimerization is done through, or occurs through a process called fusion. And fusion is when that occurs not infrequently as a typical of genetic damage. And what that means is that there is one portion of the RET molecule, and that's sort of inside of the cell here. This is outside the cell, this is inside the cell. So this intracellular portion then gets fused with another gene, which for some reason has the ability to find another copy of the same gene product. So they fuse together and then bring these two together again, and that leads to activation. Whenever you have these two sticks together, it gets activated. And this fusion partner, and there's a number of them that are possible that do the same thing. If that happens, then RET gets activated and you get thyroid cancer. This is fairly rare. This also occurs in anaplastic thyroid cancer. It's fairly rare, but there was, again, there was a study that was not specific to thyroid cancer, but more for any cancer with this kind of RET, either mutation or other alteration, fusion, such as fusion. And there were a couple of thyroid cancers, like here, these were the papillary thyroid, most of them were medullary thyroid cancers, but there were some papillary thyroid cancers, and they responded to a specific inhibitor of RET. There's two of them out there now, but you get a nice response. The other one is called Prelzetinib, very similar data. So it works beautifully. It also works for a fairly long time, in my opinion, longer than for example, Dabrafenib and Trametinib, both in anaplastic or in papillary thyroid cancer or Hurthle cell cancer. But again, in anaplastic, not many cases, and the response was here relatively short-lived. So again, this is not a genetic mutation or a genetic abnormality that you find in Hurthle cell cancers, but you find it occasionally, maybe 10% or less, in anaplastic thyroid cancer. And if you're the lucky one who has this mutation in your anaplastic thyroid cancer, there's another option. And again, this is one drug. There's another very similar drug, Prelzetinib. Not clear if you can or should use them sequentially or just one after the other. Both is probably, it's worth a try, but they're very, very similar. So in most cases, there's cross resistance.
Dr. Lorch?
Yeah.
There's a couple questions. Do you want to have? Okay. So one of them is from John and Karen. I have Hurthle cell cancer with a P10 deletion. Would in Everolimus be
Yeah.
a possible option? The cancer has metastasized to my lungs. I'm not on Lenvima.
Yeah, so yes, the short answer is yes. I think whether a P10 deletion or not, as I said, I have yet to see a Hurthle cell cancer that does not respond to everolimus. So yes, absolutely. I think if you're, I mean, the thing with Hurthle cell cancer, just like with any other thyroid cancer, is there's no need to treat it if it's not growing. Most Hurthle cell cancers, though, are. And just, despite TSH suppression and all that stuff. So yes, everolimus would be a good choice. The FDA approved option is Lenvatinib, to which Hurthle cell cancer also usually responds quite well. But if there's toxicity or you don't tolerate it or don't like it, then everolimus is a good option. And again, as I also said, if you can find a clinical trial with one of the second generation mTOR inhibitors, there are several. It's just that those companies are not very willing to test them right now. Everybody's so crazy about immunotherapy, which, by the way, Hurthle cell responds to too. But there are very few trials right now with the second generation mTOR inhibitors. But that would also be an option.
Okay, and then the second one is when you say that Hurthle cell RAI is refractory, does that mean RAI doesn't work for Hurthle cell cancer?
I think so. Yes. So it's still often used as an attempt, but I have seen cases where there was a little bit of uptake on a post-iodine scan, and thyroglobulin drops a little bit. But it's not typically a cancer that responds to radioactive iodine. We often in Boston, we often skipped radioiodine altogether.
Okay, that's it for now.
Okay. So a few more slides about genetic mutations or also outlook, what's coming. So in rare cases, there is a ALK mutation, anaplastic lymphoma kinase. Now, anaplastic, that means actually unformed, and in this case has nothing to do with anaplastic thyroid cancer. It's actually a gene rearrangement that occurs most frequently in lung cancer. And there's a whole host of specific inhibitors that work beautifully. Now, in some cases, this ALK rearrangement or mutation, usually it's rearrangements, occur in thyroid cancer, both papillary thyroid cancer, poorly differentiated thyroid cancer, and anaplastic thyroid cancer. Rare though, so there's no big study involving thyroid cancer, but there are a few case reports, and there's just like with lung cancer, when the same mutation occurs or the same fusion occurs, you can actually then go from one to a very similar other drug that also inhibits ALK, and then to the next and the third and fourth. And still get good responses out of it. So again, if you're the lucky winner in this genetic lottery, and your cancer has an ALK mutation or an ALK fusion, that is a good option because these drugs are very well tolerated. Most people don't really have any side effects at all. Again, for this, as well as for the RET mutations or fusions, you actually need next generation sequencing. This is not something that your pathologist can just do by looking at the slide or do some special stain, like for BRAF, for example. For BRAF, you can just stain and you know whether it's there or not. But for for ALK and for RET, you actually need next generation sequencing, and that's sometimes a problem because it's not always covered by insurance. If, however, you go to a larger center, whether it's Dana-Farber or Memorial Sloan Kettering or Northwestern or any of these places, there is sequencing available, and then that can be analyzed. As I said, the likelihood that your tumor will show this genetic change and that you will respond to this is very low, but still, you don't want to miss out on a good option. So how about immunotherapy? I mentioned it before. Everybody's crazy about it now, and justifiably so, because immunotherapy doesn't work very reliably, and it also, you don't even know when it's really going to work. It could work at any point, but if it does, it's great, because then it can actually make tumors go away and they can stay gone. And I'll show you a few pictures of some of those patients that I've treated and who still have not recurred, even though they're now 1.5 years or 2 years. By now, it's actually more like 2 years, 2.5 years in one case, since their last dose of immunotherapy. So I think in some cases, we can actually cure these cancers. So this is just some stuff that we've done here at Dana-Farber. And so this is a model system where you can take a tumor and put it in this grow it in a little collagen cylinder, and then it grows to these little colonies, and you can measure, and then you can treat with immunotherapy drugs, which had not been done before. Now there's a couple of systems like this, but anyway, this is kind of neat because it shows you. You can, with a little bit of imagination, you can see these little lymphocytes here. These are the inflammatory cells surrounding a tumor cell growth, a little glob of tumor cells. And if you look at like this margin here, for example, it overall gets a little lighter, and here it gets a little bit, this shrinks a little bit. Again, it's not that striking, and this is time lapse microscopy. So this is only over 2 hours, but if you do this for a day, you'll see that live cell colonies, which don't project very well, but they're right here, then die. This is a dead one. And then you can measure, the types of the substances that these immune cells then release, and which indicate that they are responding to a tumor and they're trying to attack it, and so on and so forth. So there we found that not just PD-1, but also CTLA-4, and CTLA-4 probably a little bit more than PD-1, was actually more important in the response than PD-1. So that was the basis for a clinical trial where we combined a PD-1 inhibitor and a CTLA-4 inhibitor, both established immunotherapy drugs, FDA approved for melanoma and a number of other things. And we combined that to treat thyroid cancer primarily, but also 10 patients with anaplastic thyroid cancer. And we had, this complicated schema of starting one drug first and then adding the other to try and figure out what's more important and so on. But for anaplastic, such aggressive disease, we just started the whole thing, the whole combo. We had, these are the results. So again, this works not as reliably as Lenvatinib. There are many cases where there was significant growth on immunotherapy. But then if you look at on this side, the blue ones are anaplastic. So there were 8 cases. Among those 10, there were 8 cases that we could evaluate because others didn't live long enough. So we had like these 3 profound responses and another response here, which also lasts quite some time. And then there were 4 on the other side that did not respond. So that was amazing and very encouraging. And the other group that really benefited, as you can see here, Hurthle cell is yellow. And also we had some near complete responders in Hurthle cell, which also have where the response has actually extended long after they were taken off treatment. So that's exciting because, does that mean that we can cure anaplastic thyroid cancer? Well, I think in some cases, probably. As I said, there are two of these are still without progression and more than 2 years out, and some went back on immunotherapy and responded again, and so on. So I think that's definitely an angle that we should pursue. And do we cure Hurthle cell? Well, I mean, there were not many cases overall, but that also was encouraging. So this is just the anaplastics, same data, the anaplastics taken out separately. And the red line here is that's sort of a significant radiographic response. But these are essentially a complete response. Here are some of these cases. This was a woman who was 87 years old, but was at 87 at the time of diagnosis, which is now 3 or so years ago. And you can see that the tumor here shrunk and then eventually went away and is still gone. And then another case of a very nasty tumor that had also, this person had radiation and all kinds of chemotherapy and kept coming back and was causing a lot of problems here, but then also disappeared almost completely, or basically completely. And then there's another case with a young man with just a little a tumor here, and after 2 weeks, it was actually gone, or it started to break up. I shouldn't say it's gone, but you can still see something here. But then it eventually did completely go away. He finished 2 years of treatment and is currently doing okay. So off treatment. So this is obviously all very encouraging. So I think we're confident. I mean, I'm confident to say that there's the prognosis for anaplastic thyroid cancer has completely changed. This nihilism where, you know, a few years ago, it was not at ThyCa, but it was at another meeting in Canada. There was a panel, an expert panel on anaplastic thyroid cancer, and people were bringing these cases for discussion, for discussion. And the verdict every time was like hospice, and that is no longer. This is no longer the case. Everybody should have next generation sequencing to find these rare mutations, or a BRAF mutation if it hasn't been found by immunohistochemistry, because these are good and easy options. They should also, I think, for anaplastic thyroid cancer, if I was diagnosed with anaplastic thyroid cancer tomorrow, I would want immunotherapy, and I would want it right away. But essentially, next-gen sequencing is essential. There are options. The list of options is growing. There are better and better drugs, and better and easier drugs that don't have as many side effects are becoming available. So I think being diagnosed with anaplastic thyroid cancer used to be a death sentence within a very short time period, and many people still, when they see an oncologist, they're told that they should just get their affairs in order and enjoy the rest of their lives. That is no longer what we should do here. There's a lot of options, and with Hurthle cell cancer, there have been a lot of options, and now it turns out immunotherapy also works really well in some cases, and especially when it works, then it often works for a long time, and that's exciting as well. So what are we doing? There is actually there's a number of trials that are coming up. One is the combination of Lenvatinib plus likely a PD-1 inhibitor. There is a trial at Memorial Sloan Kettering. This is all based on data from Germany, small study. Half of the study is a two-part study with a retrospective part and a prospective part, where it looks like there may be a fairly high response rate to the combination of Lenvatinib plus immunotherapy. Now, in differentiated thyroid cancer, including Hurthle cell cancer, that doesn't seem to be a good strategy. There, the response rates in a more rigorous trial, response rates are, or overall, progression-free survival and all that stuff, does not seem to be longer than with Lenvatinib alone. But in anaplastic, perhaps different, but still, again, you combine these two drugs, and of course you have a response rate that's relatively high. But is it higher than either drug alone? Who knows? What we're pursuing is a trial with a new antibody, an immunotherapy antibody that actually combines PD-1 blockade and CTLA-4 blockade in one molecule. And the idea here is that it brings the immune cells and the cancer cells closer together, because one arm binds of these antibodies. One arm binds to the tumor cell, and the other binds to the lymphocytes. And then, it sort of mechanically just brings them closer together, and perhaps for a better immune response. Who knows? This trial is about to go to the SRC, so I think we'll start enrolling patients here in Chicago in probably about 2 months or so, if all goes well. But that'll be interesting. Then there are other trials, again, combining immunotherapy with a variety of targets, or other inhibitors. And the idea isn't always to see if there's any synergy. And there are many combinations that one could think of, but most of those are not open yet. So with that, that's kind of what I have here. So I'm open for discussions.
Okay, so there's a few more questions here in the Q&A section. There's first a comment. So thank you, Dr. Lorch, for your contributions to ThyCa. We saw you first in 2019 in Denver and gleaned much hope from you. My husband is BRAF positive and benefited greatly by 16-patient trial. DT plus Pembro allowed adequate shrinkage for surgical resection, and 2.5 years doing ever so well. I have to speak out success.
Yeah, that's great. Congratulations. That's wonderful. But these are the responses that we see with immunotherapy, and that's different from what's out there, whether it's Everolimus or Lenvatinib or whatever. That's exciting. I think there's a real chance to cure these drugs. I also think that there's CAR T cell strategies coming down the pike that are now expanding into solid tumors. They don't have a good track record in solid tumors so far, but they're getting better, I think. So I think that's also something to keep an eye on. Those trials have not opened yet. We're working on one, and others are as well, I'm sure. But so yeah, the immune angle is in my opinion, is the future. I mean, if this was just our first, this was the first attempt here with there's a PD-1 inhibitor, spartalizumab, that was also tested in anaplastic thyroid cancer, has about a 19% response rate. We had sort of these 3 or 4 responders out of 10 with nivolumab and ipilimumab, but these are just the first steps. We're getting better and better with, or the drugs are getting better and better. So I would expect that as time goes on, more and more people will enjoy the benefits. And as I said, the exciting thing is that there are long-term responders, and people, I don't know if that's a cure or not, but it sure looks like it.
Here's another question. My specialty pharma company started sending me Debrafinib instead of Tafinlar. Are these exactly the same drug?
Same, yeah. One is a generic name, and one is it's not a generic. It's the same drug. It's not off patent, so it's all made by Novartis, and it's the same drug.
Um, I was diagnosed with ATC March 2021. I was started on Lenvima and Pembro. After 3 treatments of Pembro, I had serious side effects enough to go off Pembro. Since then, I'm only on Lenvima since June and having a 25% reduction so far.
Yeah.
So the question is, what are your thoughts about that?
That's great. Congratulations. Yeah, as I said, the question is whether or not, what the contribution of each drug is here. You have to keep in mind that pembrolizumab has a very long half-life. Once you've had it, it's in your system for weeks and months, and possibly years. So is it because it's responding to Lenvatinib? I mean, I hope so. But it could also still be the response of pembrolizumab. You've probably received steroid, depending on which side effects you had and so on. But steroids are, take away some of the efficacy, but usually not all of it. So you may actually, the 25% shrinkage may be from Lenvatinib, it may be from pembrolizumab. One thing that I've often done when people did not tolerate pembrolizumab is switch over. That can't be done on a trial, obviously, but switch over to Everolimus, which is a PD-L1 inhibitor. So it inhibits the same. It does the same thing essentially, and seems to be more or less as effective as pembrolizumab, but it has a much shorter half-life. The half-life is only a week or 1 or 2 weeks, and then it's gone. So for patients, especially when I suspect that they benefit greatly, and when there aren't great other options where you could just switch to the next one, I have done that and successfully, and people have been able to then, strangely, I'm surprised myself, but have been able to tolerate then Everolimus, even if they had terrible side effects on pembrolizumab. It could also go the other way around, but with Everolimus, at least the drug is gone after 2 weeks. With pembrolizumab, it isn't. So if I would say right now, with your tumor shrinking, no reason to change anything. If it starts growing again, and especially if it happens about 6 or 9 months after your last pembro dose, because I think that's sort of when the levels become subtherapeutic, I would probably be tempted to give immunotherapy another shot and then use one of those, Everolimus right now is the one that has a shorter half-life, and see if you can tolerate that.
How long do you continue immunotherapy, Pembro specifically? And if there are no signs of disease, is there a way to know the immunotherapy is working versus just the cancer hasn't returned yet for other reasons?
Yeah, that's a good question. So the short answer is not really. I mean, usually time will tell what's going on. I mean, if what we see quite a bit, and more so, I think, with immunotherapy than with Lenvatinib or any of these other drugs that I mentioned, are these mixed responses. It's very frequent that you have a couple of lung nodules, and they keep getting smaller and smaller and smaller, and even then say there's a bunch of neck nodes, and they respond initially, but then 1 or 2 start to grow. Everything else works, and continues to work and shrink, and but there's like these 1 or 2 nodules that don't somehow have not gotten the memo, and that's a little bit of a problem with immunotherapy. What we've done somewhat successfully was that we often then actually went to surgery. Just had, if it was accessible, if it was in the neck, for example, have a neck node taken out. In the lungs or in the liver or in other areas, that's usually not an option because it's much bigger surgery. But if it's easily accessible, we've just often taken it out. And strangely, and I have no explanation for it, but strangely then often the disease was remarkably stable then for quite some time. With chemotherapy, this would have, or with any other drug, going after areas that do not respond and just continuing with the same while you're having a mixed response would not work at all. But with immunotherapy in these immune sensitive cancers, it sometimes does. So then, that becomes, then things become a little bit more murky, and it's more sort of freestyle stuff that you have to do. Sometimes a little bit of radiation to a specific nodule or to the neck. There's this radiation technique called quad shot, which is not very intense, but often is enough to keep things under control, is often an option. So, those mixed responses are a problem. And the way to deal with them, I think, is a little different than traditionally with chemotherapy, where you essentially just, if it doesn't work anymore, you have to give it up and switch to the next one. With immunotherapy, you can still get responses, and I've seen all kinds of stuff with, sometimes, you do something, you irradiate a little bit, and suddenly, other nodules that kept growing in the lung that you didn't radiate also suddenly start shrinking again. Or, it's very odd, it's very unpredictable. The explanation is that, I think, is that the tumor microenvironment, these cells that I showed you dancing around these tumors, they're different from tissue to tissue and from tumor to tumor. So sometimes the composition is just not favorable enough for these immune cells to do their thing. But even though the cancer, I'm sure, is more or less exactly the same. That's where it gets a little tricky, and where it's important to see somebody who has seen that a lot to navigate through this.
So we have about 6 minutes left, so I'm going to try and get through a couple more questions. I'm going to butcher the names of these drugs, so I apologize. This person has ATC. If a patient was on 2 immunotherapies, nivolumab,
yeah,
and
ipilimumab, yeah, nivo and ipi for short.
Okay, good. They quit working and was taken off them. Is it possible for a patient to try different immunotherapies?
Yeah, the short answer is yes. Ideally, it shouldn't be the same. Now, switching, for example, from nivolumab and ipilimumab to pembrolizumab, and pembrolizumab is more or less the same as nivolumab. It's just one is made by Merck, the other is made by Bristol Myers. Probably not very promising, but again, I think, sometimes I've switched to things like Everolimus, which is also very similar, but, again, targets the same pathway, but in a different way. Seen some responses here and there. It's usually the time when things get a little dicey. Now, again, if you have, with immunotherapy, as I mentioned, there's always the possibility for the cancer to still respond. We do not understand what's actually going on in these tumors, quite simply. And, you could, depends on what, I would not give it up. What I usually do is, in these cases, is continue with immunotherapy and then add something, add Everolimus, for example. And I've done this many times. There's no trial. This is just Wild West medicine. Hoping that it'll change things around a little bit. And then change the composition of the immune system, which Everolimus can do. And I have sometimes seen responses. If the tumor is BRAF positive, then add a BRAF inhibitor back into it, even though it may have failed before. Again, to sort of take advantage of potential synergy. between the drugs. So I either switch to another type of immunotherapy, and ideally, I think in the future this should be, a CAR T cell or some other approach, or perhaps also the bivalent antibody that we're going to test in the clinical trial. Now, having been on nivolumab and ipilimumab, you would actually not be eligible for this trial. Unfortunately, even though I was trying to convince the company to sponsor a few slots for exactly that population. So there are options, but then it becomes a little bit more freestyle. I would not, but sort of to answer your question directly, would I give up? Would I go off immunotherapy? Well, if you're tolerating it well, I would not. I would rather combine it with something else.
I'm non-BRAF ATC patient and on and off Nivo and infliximab to offset symptoms of Nivo. Tumors in lungs have shrunk millimeters from centimeters. I have been on this regime for 3 years. Should I stop trying Nivo or continue the course if things are static?
If things are static, I would probably continue. As I said, sometimes switching to another drug like Everolimus with a shorter half-life might be helpful. Then that way you don't need, hopefully, not as much infliximab. On the other hand, you've been, nivolumab hangs around for a long time, just like pembrolizumab or ipilimumab for that matter. So I don't think, even if you do that, you'd probably still need infliximab to keep the side effects under control. But I would, if things are going okay, I would not rock the boat.
Unfortunately, I think we're kind of out of time. There's a minute left. So we want to thank you for your time today and for all the wonderful information that you shared with us.
Thank you very much. No, it was a pleasure. And don't hesitate to reach out. Happy to answer questions after. All right. Good. Take care. Bye-bye.